Really super happy with what we were able to come up with. And not only the breadth of the recommendations and the promise of really doing something innovative for rural health care, but also the way that we were able to, at the end, get unanimous consent. So it's not something that the state can just adopt next year. There need to be certain things that are put into place. The state doesn't have the resources, the communities don't have the resources, and so we were asked continually to come up with a priority list of all of the things that you're recommending. What are the one or two things that you have to have passed? And our work group decided, instead of making a priority list, that we would make a timeline for implementation. And so what makes sense first is to develop some policies around the workforce to encourage providers to come to rural areas through rural residencies, rural scholarships, some different tax incentives, some loan repayment, some things that have actually been tried in the past, but the work group recommendations broaden. One of the other components of the recommendations is something that we called the Rural Healthcare Complex, and it sounds like a bricks and mortar structure, and it very well could be, but essentially it's a one-stop shop for patients to be able to know that that's where they can go to at least find information about where they can get services and how they can get access to transportation to take them to those services. It can also be a mobile dental unit. It can be a nurse practitioner's office in Rock Hall. But what makes it kind of interesting is linking through information systems, so that there is a way for people to actually share some information about when the patient was seen, who the regular provider is, to be able to access more medical history for the patients that they're seeing. And so that kind of creates a little bit of a virtual network. And then what can't be handled at the nurse practitioner's office or in the mobile unit, those staff people and patient navigators, which don't have to be medical providers. They can just be lay people who are trained to understand the system and all of the information that patients might need. They would then be able to refer on to the next level, wherever that is. Within the complex, it might make sense for private businesses to co-locate and so share space. Rather than having patients have to drive across town or have to wait for a bus or some other transport that isn't always super reliable or available in a rural area, would it make more sense for there to just be one place where they can go, so that the patient really has the ease of having someone help them navigate the very complex system that's not only geographically complex but also financially complex, and in the midst of a healthcare crisis, that's the last thing that a patient wants to have to do. So we're trying to make care as easy for patients to access as possible and as close to their homes as possible. So some of those decisions might be requested of private businesses. Okay. We did make a recommendation that inpatient services remain in Chestertown, and that recommendation was validated by the School of Public Health at the University of Maryland, who was doing a qualitative and quantitative study alongside of us. They were at all of our meetings, but they were doing their own independent work, and we were doing our own independent work. And it was interesting, about halfway through, we came together, or maybe 3/4 of the way through, we came together and realized that what they were recommending was almost identical to what we were recommending based on the feedback that they had gotten from citizens and from their own qualitative data. Right now we're in a phase of needing to draft legislation for them to be able to consider when they enter Annapolis in January. So over the next couple of months, hopefully there will be some initial drafts of legislation coming out. Well, my experience in Alaska, working for a very rural area, is that at the end of the day, there are limited resources, and there's kind of a fight between urban areas and rural areas and how those resources are distributed. And I know that when we made our presentation to the Health and Government Operations Committee, they were very interested and grateful for the work that we had done. I know that Senator Middleton continues to be very supportive. Senator Hershey is very supportive, Delegate Jacobs. And so I think we have a good number of people who are going to be our allies. At the end of the day, there are going to be a couple of things that I think come into play. One of them is the lack of resources. So we have to navigate that case. And the other is that the regulatory agency, the Healthcare Cost Review Commission, actually reports to the governor. And so Governor Hogan has to step in and actually be engaged and advocate for people in rural areas and make this a priority for his administration. The other really strong ally that we need on this is the University of Maryland Medical System. They, as you know, the parent company of Shore Health, they have a very vested interest in making sure that this rural health policy goes through. In the same way that the University of Maryland Medical System put shock trauma on the radar and put Maryland on the map in terms of having an elite healthcare system, there's an opportunity for the University of Maryland Medical System to actually address rural healthcare in the same way and be very innovative. If they don't specifically and vocally advocate for what we're doing, then I don't think it's going to have much chance of going anywhere. If they do, then I think we have a very good shot of winning. Just having additional reimbursements doesn't necessarily mean that Chestertown is going to be successful. It also takes a management approach from Shore and from the University of Maryland Medical System that offers opportunities for that facility to thrive. And so there needs to be some innovation on behalf of that business. And yes, they are a private business, but they also have a very strong public interest because they're a nonprofit and they are required to provide a level of community benefit that is conducive to the benefit that they're receiving in other areas from the state. And so there's this tension, I would say, between what the public should expect and what the private business should be doing. And I think that those tensions can be relieved so long as they're making a good faith effort to really help this facility thrive. I am really hopeful that all of the effort that went into making this report and the $500,000 that the state spent on creating this report, that it actually does still have life and breath in it. Because otherwise it's just a $500,000 paperweight. And that I don't think anybody wants to see that.